Hello, my name is Ashita Tolwani. I'm professor of medicine, the Division of Nephrology at the University of Alabama at Birmingham. And today I'd like to talk to you about anticoagulation for CRRT. So this is my disclosure slide. So going on, what is the importance of anticoagulation for CRRT? So there's several things that we look at. We look at the importance is to preserve the life of the extracorporeal circuit, to maximize delivered dose, and to also achieve the goals we want of acid-base control, volume control. Importantly, also to minimize blood loss caused by clotting during continuous renal replacement therapy. And furthermore, we know that clotting and use of filters also increases therapy. So there's lots of important reasons of why we want to anticoagulate the CRRT circuit. So if you look at the statistics, when we talk about CRRT, it should be a continuous therapy running 24 hours a day. But what we can see by this slide, as many other researchers have also published, is that what we prescribe is much more than what we deliver. In other words, we deliver less than we prescribe. In this one particular study, when the prescribed dose was for something like 25 milliliters per kilogram per hour, the actual delivered dose was only in the range of about 16 milliliters per kilogram per hour, only 65 or 68% of prescribed dose. And the reason for a lot of this discrepancy is because of clotting of the circuit or downtime. So what are the factors affecting circuit clotting? So you have issues with filtration fraction if you're using high convective therapies and low blood flows. Some CRRT devices have what's called a deaeration chamber, which requires a post-filter replacement fluid as an interface between the air and the blood to prevent clotting. I cannot stress the importance of vascular access. Having the placement of a vascular access in the appropriate place is very, very essential to providing good therapy and preventing problems with the circuit. And finally, insufficient anticoagulation. So if you look at all the different anticoagulants that have been used for CRRT published in the literature, we can see, of course, unfractionated heparin, which has been the gold standard for dialysis patients for years, citrate, which we will talk about today, and other options that have been reported but not widely used are regional heparinization with protamine, low molecular weight heparin, thrombin inhibitors, prostacycline, and even nafamostat. And one of the reasons these other options haven't been as widespread is many of them still have the problem causing systemic anticoagulation and pose a huge bleeding risk to the patient. So let's look at the most common prescribed anticoagulant for dialysis therapies, unfractionated heparin. So unfractionated heparin has a lot of advantages. Of course, it's effective, we know that. It's widely available. It's very simple in terms of the monitoring involved, usually in activated PTT or now even in anti-10A levels. It can be reversed with protamine. It's inexpensive and has a short half-life. But the biggest problems are what I've recorded here or reported here on the right panel side of this slide. There's a big increased risk of systemic bleeding. And there's unpredictable pharmacokinetics because unfractionated heparin is made of different size molecules, so they're metabolized differently. So we know in that setting, since it also has anti-10A effect, the partial thromboplastin time, or the PTT, is not a reliable predictor for bleeding. Also, many of our patients who we treat with continuous renal replacement therapy are septic. And in sepsis, you have low antithrombin levels, and so you can have heparin resistance due to low patient antithrombin levels. And then, of course, there's this risk of heparin-induced thrombocytopenia. So unfractionated heparin, for all these reasons, is not the ideal anticoagulant for a continuous type of renal replacement therapy. What about protamine? Well, this is a circuit example of how protamine is given. So essentially heparin is given prior to the circuit, then protamine is given on the venous limb, the blood returning back to the patient, and of course it mitigates the effect of heparin. So essentially the anticoagulant effect is just in the circuit itself. It becomes regional. And typically, if you look at the protocols published, 100 units of heparin equals 1 milligram of protopion. So usually, giving a 1,000 units of fractional heparin is equivalent to about 10 to 12 milligrams per hour of protopion. So typically what you do is give fractionated heparin 1,000 and 1,500 units per hour, and this is followed with protamine of 10 to 12 milligrams per hour in terms of the dose. So again, the big advantage, of course, is that the anticoagulant effect is restricted to the extracorporeal circuit. But unfortunately, the disadvantage is there's a rebound effect. So essentially, the protamine heparin compound is unstable, and so heparin could be re-released afterwards and cause increased bleeding. Plus, protamine itself has lots of side effects, including hypotension and hypersensitivity reactions. Finally, this correlation of 100 units to heparin equivalent to about 1 milligram of protamine to mitigate the effects of heparin is not completely defined. And so there can be some variation in this protocol. So what about low molecular weight heparin? So essentially, many protocols exist in literature based on a fixed dose versus a dose based on measuring anti-10A levels. And those that have been looking at or who looked at anti-10A levels, they recommend the target anti-10A level to be anywhere from 0.25 to 0.35 units per milliliter. There are various types of low molecular weight heparins that have been prescribed in the literature. And I'm not going to go into details, but you can see for these particular different types what the loading dose is recommended for each one, what the maintenance dose is, and in some of these studies, what they determined as a median or mean filter life. So what are the advantages and disadvantages of low molecular weight heparins? Well, again, it's effective. You have more predictable pharmacokinetics than unfractionated heparin, and a lower incidence of heparin-induced thrombocytopenia, and a less effect on lipids as heparin does. But the problem is it's still a systemic anticoagulant, so you still have the increased risk of bleeding, which is substantial in critically ill patients. The other problem, it's only partially reversed with protamine, and not all places have access to anti-10A activity testing, so it can be expensive. So if you look at the KDIGO guidelines, which is an international group of experts in the fields of nephrology, critical care, etc., when they published, based on the evidence in 2012, recommendations for anticoagulation during CRRT, what essentially they came up with is that regional citrate anticoagulation should be your first line for patients on CRRT. And so their final suggestion is for anticoagulation CRRT, we suggest using RCA or regional citrate anticoagulation rather than heparin in patients who do not have a contraindication for citrate. So there you go. Those were the recommendations in 2012. And what were these recommendations based on? Data. So there have been multiple trials comparing citrate to heparin or citrate to Levinox, other low molecular weight protocols, or citrate to even regional heparinization. So if you look at this meta-analysis of randomized controlled trials, specifically looking at citrate versus heparin, meta-analysis consisted of 11 randomized controlled trials with almost 1,000 patients. And what this trial determined is that there was a statistical significant decrease in circuit loss when patients were treated with citrate as compared to heparin. There was also decreased bleeding. And when it came to looking at electrolyte abnormalities, there was no difference in metabolic alkalosis and no difference in mortality. And since this meta-analysis has been published, there's been another recent randomized controlled trial comparing citrate to heparin, which showed the same results, that citrate was more effective in keeping circuits patent than heparin. So there's data. So now let's talk about the mechanism. How does citrate work as an anticoagulant? Well, here you have the coagulation cascade, and what you can see is calcium is required for almost every step. So the concept is very simple. So if you provide citrate in the circuit, you essentially chelate calcium. And if you can get the ionized calcium or free calcium low enough in the circuit, you can't clot the blood because citrate prevents the activation of these calcium-dependent procoagulants. You can measure this anticoagulant effect by the ionized calcium level. And what happens then, you can reverse this effect by providing a calcium infusion back to the patient to ensure that the ionized calcium in the patient remains in normal levels. What's important to note when we talk about citrate accumulation is that when citrate and calcium combine, they form calcium citrate, which is biologically inactive, but is measured as total calcium since that's bound calcium. So in terms of metabolism, citrate has a plasma life at about 5 minutes, which is prolonged to about 20 minutes in renal failure. It is rapidly metabolized by the liver, kidney, muscle cells, and of course, mostly it's the liver. And if you're using trisodium citrate, 1 mole of citrate is actually metabolized to 3 moles of bicarb, as you can see in this figure here. And so not only does citrate have an anticoagulant effect, but in someone who has a functioning liver, it can also provide a buffer. So just to give you a perspective about citrate and how much it takes to cause an anticoagulant effect, we do have normal blood levels of citrate that range about 0.05 millimoles per liter. Bleeding time is prolonged to infinity at a citrate concentration in the blood of 3 to 5 millimoles per liter, and this correlates roughly to an ionized calcium level of less than 0.35 millimoles per liter. It's important to recognize, though, that we give citrate often in other products to patients, and mostly in blood products such as FFP and packed red blood cells. And so this may also have an effect on ionized calcium levels on patients who are being treated with citrate anticoagulation. So many studies have looked at the relationship between citrate and clotting time. This is one study that was published in 2001, and it was an ex vivo study. And what they demonstrated is there's a dose-dependent inhibition of coagulation with increasing citrate concentration. However, there was absolutely no anticoagulant effect or almost no effect when the ionized calcium was less than 0.50 millimoles per liter. So you can see here the clotting time, the calcium, ionized calcium levels, and the citrate levels, the correlation, and essentially that's where we come up with the guidelines of the ionized calcium target ranges for those treated with CRRT with citrate. So this shows you, it's the same study, but it basically shows you again in a graphic form the dose-response relationship between the calcium level and clot formation. And essentially, just to summarize, what they discovered, if you look at the post-filter ionized calciums and clotting time, essentially the best effect was with the post-filter ionized calcium less than 0.33 millimoles per liter. Anything else was concentration dependent and very little effect when you got to an ionized calcium level of greater than 0.56. Similarly, another study showed the same type of pattern. This was a study looking again at dose-response relationship between calcium levels and clot formation. This was another in vitro study. So they took blood from healthy volunteers and they performed or treated this blood with ACDA in different amounts. And then calcium levels were measured as well as clotting times. And this showed the same type of relationship. The best effect seemed to be with a ionized calcium level in the filter of less than 0.33, or in this study 0.25. Anywhere 0.25 to 0.5 millimoles per liter was concentration dependent, and above 0.5 millimoles, almost no effect. If you look at the clearance of citrate, the clearance is the same as urea because citrate is a small molecule. And so with small molecules with CRRT, you have complete equilibration where the molecule is essentially the same concentration in the effluent as it is in the blood. And so this is called the sieving coefficient, and the sieving coefficient for citrate tends to be close to 1. When you talk about the modality clearance, in terms of, does the clearance differ between CRT modalities? No, there's no difference since it's a small molecule between using convective therapy versus diffusive therapy with CRT. The clearance, however, does depend on the concentration in the filtration fraction, as well as the CRT dose. In general, though, looking at the typical dose that we use for most CRT patients, i.e., 25 to 30 milliliters per kilogram per hour, in those specific patients with the typical blood flows we see with CRT, about 40 to 60% of the citrate is cleared through the dialyzer. So you can see already, compared to the other anticoagulants that I've discussed, citrate has some real advantages. It's regional, so it avoids bleeding complications systemically. It can double as a buffer. And all the studies to this date, randomized trials, have shown it's more effective than heparin and safer. Also, there's no thrombocytopenia, as can be associated with heparin. So therefore, it is an optimal anticoagulant. But it does not come without some disadvantages. Since citrate is converted to bicarb, there's potential for metabolic complications, especially since it also chelates calcium and magnesium, and we'll talk about those soon. And because you're monitoring the cyanide levels, calcium levels in the circuit and in the blood, you can have some laborsome protocols or detailed protocols are involved, protocols that are a little bit more complex than with unfractionated heparin. So let's talk about these potential metabolic consequences of citrate. So if you give too much citrate and the liver is working, and if you're getting buffer from other sources, then you can have a metabolic alkalosis. So this is more of a citrate overdose, not so much a toxicity. The citrate is not accumulating per se in the blood, it's getting metabolized. You're just giving an excess of citrate, and therefore it's being metabolized to bicarb. What's more concerning is metabolic acidosis in the setting where citrate is not being metabolized. So what happens is that when the calcium citrate complex enters the blood, if the liver is unable to metabolize the citrate, the calcium in citrate basically sits as an anion in the blood and causes a worsening anion gap acidosis. And we will talk about that in the next few slides. And this mostly occurs, as I mentioned, in situations of hypoperfusion or where the liver is not functioning. You can also get hypernatremia. And the reason for this is many of the citrate formulations used worldwide are used in blood banking. And the typical formulations like 4% sodium citrate or ACDA have high levels of serum sodium concentrations in them. Finally, as I've already mentioned before, since citrate chelates calcium and requires a calcium infusion, you can have problems with hypocalcemia or hypercalcemia. Citrate also chelates magnesium, although not as strongly as calcium. But because of this, you can see hypomagnesemia, and you can have inadequate replacement of magnesium loss. So let's talk about citrate toxicity, not where you're giving excess citrate and it's being metabolized, but where you're giving citrate and the liver is not able to metabolize citrate. So again, the biggest risk factors that have been documented in the literature is hepatic dysfunction. And interesting enough, lots of literature has shown that citrate can be used in cirrhotics. It's mostly those with shock liver, high levels of transaminases, or cardiogenic shock that predispose you to lactic acidosis. So any sort of systemic disease that causes hypoperfusion with elevated lactate levels puts you at risk of having the citrate stay in the blood chelated to calcium and not getting metabolized by the liver. So again, how do you detect this? Well, the calcium citrate sits as an anion in the blood, if it's an anion. So you have a worsening metabolic acidosis since there's no buffer provided from the citrate, and since it is a acid sitting in the blood, okay? Essentially, you have an increase in anion gap, and since the citrate is binding to calcium, your ionized calcium in the blood continues to be low, which is followed by the response of escalating the calcium infusion. So what happens is, since calcium binds citrate binds calcium, the total calcium levels, which is bound calcium, increase compared to your ionized level. So most of the time we say that 50% of calcium is bound. And so that ratio of total calcium to ionized calcium is about 2 to 1. So if you see that ratio increasing to greater than 2.5, all measured in millimoles per liter, then that's an indication of citrate accumulation. And it's not just one of these things that indicates that citrate is accumulating. It's the trend of all of them. Worsening metabolic acidosis, elevating total calcium levels, increasing calcium infusion requirements, and then the total calcium to ionized calcium ratio of greater than 2.5. So this is the calcium gap, or the elevated total calcium to ionized calcium ratio, depicted in a nice graph. As you can see, the normal calcium, total calcium to ionized calcium ratio is about 2 to 1. But if you're having citrate bound to calcium, it's not getting metabolized, this raises your total calcium level. At the same time, your ionized calcium is falling to replete the calcium that's being complexed to citrate. So you can see how your total calcium to ionized calcium ratio increases beyond 2 to 1. And 2.5 is kind of the magic number. All right. So given that citrate can cause these metabolic abnormalities, it's really important to understand the acid-base complications of citrate delivery management so you can troubleshoot them. So one scenario, which I've already described, is citrate excess. That is where you're giving too much citrate, the liver is working, and you have excess buffer. And how you diagnose this? You have a metabolic alkalosis. And in this situation, since citrate bound to calcium is not just accumulating in the blood, your total calcium to ionized calcium ratio is normal. How do you manage this? Several ways. If you decrease the blood flow rate, that automatically will require you to decrease the citrate amount to achieve the therapeutic citrate goal in the blood of 3 millimoles per liter, or a post-filter ionized calcium of less than 0.35 millimoles per liter. So this means that there's less citrate entering the systemic circulation to cause metabolic effects. You can also increase the dialysate rate to basically dialyze off more citrate, or you can decrease the buffer concentrations in the other CRT solutions you're using. So perhaps if you're using a buffer of 32 to 35 milligrams per liter in terms of bicarb, maybe using a solution that has a bicarb concentration of 22 to 25, something like that. Second complication is what I've already talked about, is citrate toxicity, but I think it's important to repeat how you determine that. This is again where citrate is chelated to calcium in the blood and it's not being metabolized, so it continues to chelate calcium. So you have decreased metabolic conversion of citrate, and this results in the accumulation of the citrate calcium complexes in the blood. And again, the detection is you have a worsening anion gap metabolic acidosis, escalating calcium infusion rates, and a total calcium to ionized calcium ratio greater than 2.5. Now, the reason we are concerned about this particular event with citrate is not because so much that citrate is toxic itself, it's the effect on the ionized calcium levels. So most protocols for citrate, which we'll talk about, measure ionized calciums every 4 to 6 hours. If citrate is accumulating and binding calcium, the systemic or patient ionized calcium can fall precipitously very fast before it's noticed and cause these complications of hypoionized calcemia, which are hypotension, arrhythmias, VTAC, and then cardiac arrest. So when you have someone who suspects citrate toxicity, how do you mitigate it? How do you manage it? Well, again, you can decrease the blood flow rate because that then requires less citrate to be infused to, again, achieve that therapeutic citrate concentration in the blood, and then therefore less systemic absorption of citrate and less side effects. You can again increase the dialysate flow rate to remove more citrate. Some institutions may tolerate a higher post-filter ionized calcium level of maybe 0.4 to 0.5. Or if you really have complications or are concerned about that, then of course discontinuing citrate would be the best thing to do. So what about the last scenario? This is citrate deficit. And what I mean is not deficit in the way that you're not having adequate anticoagulation. I mean deficit in that the amount of citrate you're giving to anticoagulate the circuit is just not providing enough buffer for the patient. In other words, the patient may require extra exogenous bicarb. So this is where the metabolic conversion of citrate to bicarb results in just not enough buffer. So you see a metabolic acidosis, typically not an anion gap. Your total calcium to ionized calcium ratio in this setting is normal. So what can you do? You can provide more citrate systemically. So by increasing the blood flow rate, this will require an increase in the citrate amount, and therefore you have increased systemic absorption of citrate and increased metabolism to bicarb. You can decrease the dialysate rate or effluent rate to cause decreased removal of citrate, or you can change the buffer concentration, your other CRT solutions, if you have another concentration available, to a higher buffer concentration. So those are your different options, but you need to really be aware of these complications and how to troubleshoot. So now that we talked about the mechanism, some of the things you need to think about, let's talk about actual protocols. How do we use it? Well, how we use it and the protocols we develop depend on the type of solutions you're using, the type of citrate solutions, the method of citrate delivery. In other words, are you going to use a fixed level of citrate or amount compared to a fixed blood flow amount, or are you going to titrate it according to an ionized calcium level? And finally, it also depends on the different types of CRT modalities you use. So let's go through this. So these are examples of commercially available citrate solutions available all throughout the world. Again, most commonly in the United States at this time, the 4% trisodium citrate and the ACDA are used. These again are used for blood banking. They're not approved by FDA for use for citrate anticoagulation, but they're commonly used, probably the ACDA more than any others. And you can see again, as I pointed out previously, that the concentration of sodium in these solutions is high. There are other solutions available outside the United States that are a dilute citrate solutions. In other words, they are not only an anticoagulant, but also are used as a replacement fluid for convective therapy and given prior to the filter. So you can see that there's a prismocitrate with all these three solutions have essentially they're isotonic solutions with a near normal or normal sodium concentration. They're very dilute compared to the 4% and 2.2% and have various concentrations of trisodium citrate. So if you look at all the different citrate protocols from various institutions, and it can be overwhelming, but it's actually quite easy. Despite the different types of citrate used, different formulations, despite the different CRT modalities, the bottom line is this. The amount of citrate delivered in the blood for adequate anticoagulation is the same. You're trying to achieve 3 to 5 millimoles per liter of citrate in that blood, which correlates, as I've shown you in other studies, with an ionized calcium level, ideally less than 0.35 moles per liter. So that's your target. So how do you achieve this target dose? So you can achieve it by knowing what your blood flow is, knowing what the concentration of citrate you're using, and then calculating how much of that citrate solution you need to use based on the citrate solution you're using, the composition, to achieve a blood citrate concentration of 3 millimoles per liter, which is what's most commonly targeted. So you can do that, do the mathematics yourself, or there are tables in the literature such as this one that show you how much to give based on your blood flow rate. So here are the most common ones used: 4% trisodium citrate, ACDA, and prismocitrate, also known as Regiocit. This is the dilute citrate that is isotonic. So you can see for the various blood flow rates, the amount of citrate you need to give based on your formulation to achieve that therapeutic concentration of 3 millimoles per liter. And of course, the more dilute the solution, the higher the rates of that solution you're going to need. And therefore, you can see at the most common blood flow rates from 100 to 200 milliliters per minute used for CRRT, that the prismocitrate or regiocitrate, being a replacement fluid and a citrate solution, provide the typical ranges of pre-filter replacement fluid you'd be using for these patients. So let's look at it from the circuit. So what I presented in that table before is essentially how you can target the citrate rate based on a fixed blood flow rate. The other way is to target citrate by actually titration based on your post-filter ionized calcium. So this is how this works. So citrate, again, is given right where the CRRT circuit is connected to the patient's dialysis catheter. Citrate chelates calcium in the blood. Technically, your other solutions used for CRRT when you're using citrate are calcium-free, and this basically just increases the efficiency of the system. A post-filter ionized calcium is monitored and measured to keep that ionized calcium less than 0.35 millimoles per liter. Then, as the calcium citrate returns back to the blood, it normalizes the calcium, prevents systemic anticoagulation. Citrate is metabolized primarily in the liver to bicarb. The bound calcium is released. But you still have to provide a calcium infusion through a separate line or through the return line of the CRRT circuit to replace the calcium and citrate lost in the effluent. And typically, the calcium infusion rate to mitigate the effect of citrate is about 1.7 millimoles per liter of the CRRT dose. Now, here, as you can see in this figure, we say calcium-free. But just know that you can use calcium-containing solutions with citrate. The biggest issue is just to recognize that if you have calcium-containing solutions, you're going to require more calcium to chelate the calcium in the solutions and in the blood to achieve that therapeutic post-filter or target post-filter ionized calcium level. So now let's look at the modality options for regional citrate anticoagulation. First of all, it doesn't matter which modality you use, CVVH, CVVHD, or CVVHDF. Citrate has to always be given prior to the circuit in order to anticoagulate the circuit. So typically, based on the available citrate formulations, regardless of whatever modality you use, you're either going to use a separate citrate solution, a separate replacement fluid if you're using convective therapy, or if you have one of those citrate solutions that I've already pointed out that serves both as a replacement fluid and citrate, you would have only one solution. So here for CVH, for example, you can have an isotonic citrate solution or a isotonic or hypertonic citrate solution with a replacement fluid. Similarly, for diffusion modalities, you can either have an isotonic citrate solution, as we've already discussed, or a hypertonic citrate solution and essentially the dialysate and calcium as provided in the other schematics. When you monitor citrate, there are many monitoring protocols out there, but typically this is a most common protocol, which I've listed here. Most institutions measure circuit serum calcium every 6 to 8 hours, and this is a ionized calcium through the circuit. And of course, the target range is to keep it less than 0.35 millimoles per liter. Similarly, the patient serum calcium is measured every 6 to 8 hours, and the calcium infusion titrated to keep the patient's systemic ionized calcium in normal range. Then, of course, you're going to measure, and this is in addition to your regular electrolyte course, you're going to measure serum total calcium, phosphate, and magnesium at least every 12 hours, and then your usual glucose, potassium, arterial blood gas monitoring, other electrolytes like you would do with any other CRT protocol. What we do at our institution at UAB essentially is that we measure the post-filter and systemic ionized calcium 1 hour after the patient's been started on citrate anticoagulation, then every 6 hours. And the purpose of that 1 hour post-filter and systemic ionized calcium is ensure that everything is going in the correct direction and that we are not having any errors in the type of solutions that we are providing. So we talked about citrate accumulation and the concern of citrate toxicity when the liver is not working. So what is the best way to mitigate this effect? And I've already pointed this out indirectly. If you have low blood flows, then it requires less citrate to anticoagulate the circuit and less systemic absorption of citrate and less systemic effects. So if I were to pick the ideal blood flows, anywhere in the literature with citrate is 100 to 180 milliliters per minute, but I would argue even 100 to 130 milliliters per minute, the lower the better, okay? To be aware, when you use citrate, especially with the concentrated formulations, the convective techniques have a higher risk of metabolic complications because they don't have like a diffusive-based therapy to mitigate the effects of citrate. Something to consider if you use really low blood flows, you have high filtration fraction, that can lead to high filtration rates, that can lead to a high filtration fraction, increase the risk of membrane clogging, and decrease calcium citrate complex clearance. This is mostly theoretical. In our experience, even with higher filtration fractions that are recommended, we have not had issues with citrate anticoagulation in terms of clotting. However, with convective therapies, because of this, using a diluted citrate solution as a pre-dilution replacement fluid can minimize this risk. The other thing is to reduce the risk of citrate accumulation, you can use higher dialysate and filtration rates to increase citrate removal. So I've basically described all this to you before, but this is a nice summary to emphasize these points. So now let's focus on another topic or change gears a little bit. We all know the challenges the world has experienced using CRT with COVID-19 patients. And so we know that CRT circuit failure has been a major issue. We have experienced it at our institution. And the reasons for clotting in these patients are multiple, not just a single reason. But the most predominant reasons are related to a cytokine storm that we know that COVID patients can develop. And also that these patients often develop a hypercoagulable state. And there are many studies now. This is one study of demonstrating the high risk of thrombosis in patients with severe COVID-19. This is a multi-center prospective cohort study, which showed that in 150 ICU patients with COVID-19, 64 thrombotic events occurred. 97% of CRT patients had circuit clotting, especially with no anticoagulation used. And of course, this has been reported over and over by many, many centers. So with this, what have been the options that various institutions have used? Well, I think most institutions have recognized no anticoagulation is not an option. Many centers have been very successful with using regional citrate anticoagulation as their only anticoagulant. But in these patients who tend to be hypercoagulable and have parameters that suggest hypercoagulability, they have essentially pushed the ionized calcium levels in the circuit to even less than 0.3. Similarly, we've done the same. Other centers have used both subtherapeutic heparin, meaning that targeting PTTs of 45 to 50, while others have used therapeutic systemic heparin in the circuit, targeting PTTs between 50 to 80. Some have been successful using low molecular weight heparin. Some have tried direct thrombin inhibitors. And a few centers, including ours, for the most part, we have been able to be successful with using citrate itself. But there are patients who, despite using citrate separately, or even trying heparin separately, have had some hypercoagulable issues. And in these situations, we have been very successful with combining citrate and heparin. So there's a lot of options, but honestly, at this point, the optimal anticoagulation regimen for CRT patients in patients with COVID-19 is unknown. I think we will be seeing more come out in publications as we get more experienced with ideal anticoagulants. And I know that several centers are performing this type of research. But I think the biggest point is to understand that some type of anticoagulation should be utilized in COVID patients, and that if you have an anticoagulation protocol at your institution, that's probably what you should stick with for safety purposes. So in summary, anticoagulation really does facilitate optimal function of the CRT circuit, which is really essential to providing patients continuous care. We know that no anticoagulation can be used in certain patient populations, but often it is associated with decreased filter life, multiple clotting, and inadequate delivery of CRT dose or inadequate correction of acid base or volume status. There are distinct advantages of citrate over heparin. There are many randomized trials that have now shown that. You have increased filter life and decreased bleeding risk and decreased transfusions. But you have to understand the limitations of citrate. You have to understand its mechanisms, the risks of metabolic derangements and how to correct for them, how to create a detailed regimen, how to monitor for patients, especially those who are at higher risk of having citrate accumulation, and really be vigilant about recognizing patients who are at risk for citrate toxicity and how to diagnose it and manage it. So thank you very much.